We're now going to begin a chapter devoted to pediatric surgery. I have arranged the vignettes by the age in which we recognize a problem. Because after all, age is the very first item of information in every question on the exam. And so we'll have first those things we recognize at the time of birth or during the first 24 hours, and then we'll proceed with conditions that are typically identified a little bit later. And at the end of all the vignettes, we're going to have a recap, because as you're going to notice when we go into the vignettes, in pediatric surgery there are many key words. By that I mean many expressions that are often used that just when you read that expression you already know what the diagnosis is. So let's go ahead and begin. Begin number one. Within 8 hours after birth, it is noted that a baby has excessive salivation. Here is the first example of an expression that immediately has a diagnostic meaning. Because it would be extremely rare, if you are a practicing physician, that you would have a patient walk into your office and say, "Doctor, I'm very worried. I think I make too much saliva. Can you check me?" And so when you read excessive salivation and it's on the day of birth, you already know there is esophageal atresia. This kid cannot swallow the saliva. And esophageal atresia usually comes with a tracheoesophageal fistula. So let me keep reading. A small, soft nasogastric tube is inserted, and the baby is taken to X-ray to have a babygram done. Now, let me pause for a second again. A babygram is an expression that we use, in fact, in pediatrics in this country. A newborn baby is about this big. An X-ray plate is this big. So you don't send a newborn to the X-ray department and say, "Please give me an X-ray of his leg." You send the baby and they take a picture of a whole baby. And that's the babygram. All right, so the gentleman, the little kid here, the little gentleman has a babygram done. The film shows the tube coiled back on itself in the upper chest. There is air in the GI tract. Now you have the whole thing. Now you know there's esophageal atresia. That's why he cannot swallow the saliva. That's why the NG tube coils back. And he's got that TE fistula that frequently comes with it because he's got air in the GI tract, and it got there by way of a tracheobronchial tree. So this child has a blind end of the esophagus at the top, and the lower half of the esophagus is connected to the tracheobronchial tree by the fistula. All right, so we already have a diagnosis. This child has a tracheoesophageal fistula with esophageal atresia. And you might say, let's go ahead and fix him. But no, we cannot do that yet. Because this happens to be a condition that is part of a constellation of congenital anomalies that we often see several of them at the same time in the same patient. And the mnemonic we use to remember what they are is VACTOR. Vertebral anomalies, anal anomalies, cardiac anomalies, tracheoesophageal fistula, and renal and radial anomalies. We already have a babygram in which we diagnose the TE fistula. In that same babygram, we can look at the vertebral bodies and the radial bone for those anomalies. Then we look at the anus on physical exam to see if there are anal anomalies. We do an echocardiogram for the heart, and we do a sonogram for the kidney. And now that we've done all that, if all there is the TE fistula, then we go ahead and repair it. If there are other components that perhaps would have to be repaired before the TE fistula, then we put a gastrostomy tube, because we don't want the reflux from the stomach to get up into the tracheobronchial tree and damage the tracheobronchial tree. All right, vignette number 2 gives you another way to look at the same vector, where it presents with another one of the components. Vignette 2 says a newborn baby is found on physical examination to have an imperforate anus. Well, this is part of a vector constellation. This kid needs the little soft nasogastric tube to be placed, pictures to be taken. He needs the echocardiogram, he needs a sonogram for the kidney. If we end up then realizing that all he has is imperforate anus, then you look on the physical exam to see if the vignette says that there is a nearby fistula. A fistula to the perineum in little boys or a fistula to the vagina in little girls, because if there is a fistula, even though there is no proper anal opening, then there is no emergency. We can wait until this baby grows before we do a surgical reconstruction. If there is no fistula, though, there is no place for the GI tract to empty, and then we next determine what is the level of the imperforate anus. We do another X-ray where we tape a little metal marker to the anal dimple, hold the baby upside down so the air goes up in the rectal vault as high as possible, and we take pictures. If the air inside the rectum and the little metal marker are almost touching each other, we have what's called a low imperforate anus. It would be a simple matter to go to the operating room, make a little opening in the center of the anal dimple, and connect the two. But if we realize there is a big gap between the two, this is going to require much more extensive reconstruction. We better do that in a bigger baby, so what we do right now is only a colostomy, and a couple of years later then a proper repair. Now we move to vignette number 3. A newborn baby is found to be tachypnic, cyanotic, and grunting. The abdomen is scaphoid, and there are bowel sounds heard over the left chest. An X-ray confirms that there is bowel in the left thorax. Shortly thereafter, the baby develops significant hypoxia and acidosis. This is a congenital diaphragmatic hernia. We always see those on the left side and not the right, because on the right side you have the big liver in the way and the bowel doesn't have opportunity to get into the chest. But if there is a defect in the diaphragm on the left side, the bowel can get up there. And you might say, we got the diagnosis, let's go fix it. No, we cannot. The problem for these babies is not the hole in the diaphragm. The problem is the hypoplastic lung. That lung on the left has not developed properly. And it'd be much safer to intervene in this baby when that lung has matured a little bit. We're talking about a few days of respiratory support, allowing the baby to mature so that then a surgical repair of the diaphragmatic defect can be done. Let me add a bit about this condition. Nowadays, that it's common for an expectant mother to have a sonogram done to find out if she's going to have a boy or a girl. The sonographer very often can diagnose this condition if it is present. And so we today learn about the presence of a diaphragmatic hernia before the baby's birth. Not only that, but the radiologist may be able to tell us the degree of problem that baby is going to confront at the time of birth. And if we realize this is going to be a big, difficult problem, then we arrange for the delivery to take place at a very sophisticated medical center where the baby can have the latest, most advanced support. And the most advanced support is a machine called ECMO, extracorporeal membrane oxygenation, which is a way to maintain the baby alive for several days until there is the proper necessary maturation of the lung. Let's move into the next. We're now on vignette number 4. At the time of birth, it is noted that a child has a large abdominal wall defect to the right of the umbilicus. There is a normal cord, but protruding from the defect is a matted mass of angry-looking edematous bowel loops. Let me read you the next, because there are two conditions that are very similar to each other. The Ch5, a newborn baby, is noted to have a shiny, thin, membranous sac at the base of the umbilical cord. The cord goes to the sac, not to the baby. And inside the sac, one can see part of the liver and loops of normal bowel. The first of these two conditions that I read is gastroschisis. The second one is omphalocele. Obviously, on both of them, we have to do a repair of that abdominal wall defect and put the bowel inside the abdomen. But often this cannot be done on the day of birth because the bowel has developed outside of a peritoneal cavity and there isn't room inside. And so we take the baby to the operating room and do a rather ingenious procedure. We create a little container of plastic. This is typically silastic, like a little tube of silastic that we sew up to the baby's abdominal wall that now contains the bowel, closed and properly protected. In the baby that has gastroschisis, we also provide venous access for total parenteral nutrition, because a baby whose bowel developed in the amniotic fluid has a very angry edematous bowel that doesn't work for perhaps up to a month. But once we've put the bowel into this little container, which by the way pediatric surgeons always refer to as a silo, once the bowel is in that silo, the baby goes back to the pediatric neonatal intensive care unit, and then every day thereafter we squeeze a little bit of the bowel into the abdomen and put a clamp, and the next day the same, and the next day the same, and about a week later all the bowel is in the belly. At that time we go back to the operating room, throw away this little plastic device and close the abdomen. Our vignette number 6 looks a little bit like the previous two, but it's a different problem. A newborn is noted to have a moist medallion of mucosa occupying the lower abdominal wall, above the pubis and below the umbilicus. It is clear that urine is constantly bathing this congenital anomaly. That congenital anomaly is an extrophy of the urinary bladder. The pubic bone doesn't meet in the midline, and the bladder has only the posterior wall. It doesn't have an anterior wall and is exposed. And this congenital anomaly is pretty rare and requires a high degree of expertise for a proper correction. And the proper correction is most likely to be successful if done within the first 1 or at the most 2 days of life. So obviously the answer here is immediate transfer of this baby to a highly specialized institution where pediatric, urological, surgical skills are available. Now we move to vignette number 7. Half an hour after the first feed, a baby vomits greenish fluid. Let me stop for a second. This is always significant. You know, little babies burp and vomit and mess things all the time. But the innocent, normal burping and vomiting is not bile stained. When it is bile stained, when you read on an exam question, a newborn has green vomiting, bile stained vomiting, there is something wrong with that child. So we have something important happening here. Let's keep reading. The mother had polydramnios, the baby has Down syndrome. X-rays show a double bubble sign, a larger air fluid level in the stomach and a smaller one in the first portion of the duodenum. There is no gas in the rest of the bowel. I'll show you a little bit later a picture like this. But what we are describing is a very classical radiological finding. So it's a baby on the first day of life, green vomiting, and then we see the stomach full of air and the duodenum full of air and no air anywhere else. And there are 3 conditions that can be responsible for this: duodenal atresia, annular pancreas or malrotation. Let me add at this point that sometimes in malrotation we see a little gas beyond the double bubble, but it's not completely diagnostic. Now, all three of these will require surgical repair, but malrotation requires it in a more urgent manner. Because in malrotation, the small bowel is all dangling from the mesenteric vessels. It's not fixed to a mesentery. And it could very easily twist to the point of cutting off the blood supply and the bowel dying. So a pediatric surgeon who's told a newborn baby had green vomiting, we've done a babygram, we see a double bubble, what should we do next? That pediatric surgeon will ask for barium studies, either upper GI or barium minima, to make a complete proper diagnosis as to whether the problem is malrotation or not. If the problem is not malrotation, the baby could be operated on tomorrow at a convenient time, but if the problem is malrotation, we intervene immediately. Let me read the next vignette because this, talks about the same issue here. Half an hour after the first feed, a baby vomits greenish fluid. X-rays show a double bubble sign. Larger fluid level in the stomach, smaller one in the first portion of the duodenum. There is air in the distal bowel, beyond the duodenum in loops that are not distended. This is highly suggestive, I'm repeating now, highly suggestive of malrotation. So you know what you want to do. You want the barium studies either from above or from below, because the diagnosis of malrotation has to be established early and the treatment has to be done right away. Now we move to vignette number 9. A newborn baby has repeated green vomiting during the first day of life and does not pass any meconium. Except for abdominal distension, the baby is otherwise normal. X-rays show multiple air fluid levels and distended loops of bowel. So now we do not have the double bubble, 2 big blobs of air. We have air fluid levels everywhere. This is most likely intestinal atresia. Intestinal atresia is a very interesting disease. It is not a congenital anomaly. It has nothing to do with genes and DNA. Intestinal atresia occurs secondary to an in utero vascular accident. A little segment of a bowel lost its blood supply and did not develop. It's missing, it's absent. We operate on these babies and we connect surgically the bowel at the point where there was the missing segment or missing segments. I'm going to revisit, by the way, this issue a little later, because occasionally we see this identical presentation, and when we operate the baby, we find to our surprise that all the small bowel is there. We thought it was intestinal atresia, but it's not. And in that case, we may be dealing with a ganglionic megacolon that affects the entire colon. But your first diagnosis when you see the vignette that I just read should be intestinal atresia. We're now going to review again some of these topics in pediatric surgery. So let's begin with the key words. Excessive salivation on the day of birth. That's esophageal atresia, usually with a tracheoesophageal fistula. On the other hand, when you read trouble when a premature baby is first fed, that typically means necrotizing enterocolitis. When you read in a question on the exam that there is bilious vomiting, a ground glass appearance on abdominal x-rays, and a family history of cystic fibrosis, that's meconium ileus. If you have a question of a 3-week-old with projectile vomiting and an olive-sized mass, that's hypertrophic pyloric stenosis. And if it is a 9-month-old, intermittent colicky pain, current jelly stools, the problem is intussusception. Let's remind ourselves also that green vomiting in a newborn means there is a serious problem. And you do a babygram. And if that babygram shows a double bubble sign, it's either duodenal atresia or annular pancreas or malrotation. Do barium studies. Let's continue on this other vignette, because malrotation requires immediate surgery. On the other hand, when a baby has intestinal atresia, what we see on the babygram is multiple dilated loops. And if during surgery for a baby that we thought had intestinal atresia, we find all of the small bowel is present, then we should suspect pancolonic aganglionic megacolon and do frozen sections of the appendix. Here is a picture of tracheoesophageal fistula, where we see the connection between the tracheobronchial tree and the GI tract. And this is a very classical picture for congenital diaphragmatic hernia. You see all that bowel up in the left chest. And you can understand easily when you look at that picture why that lung didn't have a chance to develop. Normally, it's an atretic lung and needs the period of maturation before surgery can be done. And here is a picture of the gastroschisis that we were talking about. Angry looking, matted, edematous loops of bowel outside of the baby's intestine. That gives me the baby's peritoneal cavity. And here is an omphalocele, and you can see the difference between the two. In the omphalocele, there is that little sac that houses and protects the bowel, and you can see that the cord goes to the sac instead of going all the way to the baby's abdominal wall. All right, so this is the end of the conditions we see at birth.